we have to take away that negative stigma that comes from inductions. Yes, does an induction versus regular labor, do inductions cause more C-sections? Of course, yes. But it doesn't mean it has to be that way. The data tells us it's not normally. So as long as we take into account different ways to start said induction, I think you can have fantastic outcomes regardless of how you want to deliver.
Motherhood is all-consuming.
Having babies, nursing, feeling the fear of loving someone that much.
And there's this baby on your chest, and boom, your entire life has changed.
It's a privilege of being your child's safest space and watching your heart walk around outside of your body.
The truth is, I can be having the best time being a mum 1 minute, and then the next I'm questioning all my life choices.
I'm Lo Mansfield, your host of the Lo and Behold podcast. Mama of 4 littles, former labor and postpartum RN, CLC, and your new best friend in the messy middle space of all the choices you are making in pregnancy, birth, and motherhood. If there is one thing I know after years of delivering babies at the bedside and then having and now raising those 4 of my own, it is that there is no such thing as a best way to do any of this. And we're leaning into that truth here. With a mix of real life and what the textbook says, expert insights, and practical applications, each week we're making our way towards stories that we participate in, stories that we are honest about, and stories that are ours. This is the Lo and Behold podcast.
Today's guest is a very big deal. He wouldn't tell you that, but I'm going to tell you that because he is the first man that I've ever had on this podcast. And it is not my husband, Kelvin. It should be, but it's not yet. I'm still trying to get him to sit here next to me. But for today, we have Dr. Hunter here. He is a practicing OBGYN. He's from Charleston, South Carolina, grew up, spent his younger years in South Carolina, and then trained and now is practicing in Virginia. He's married to his wife, who's also a nurse, and they have 3 kids. They are 18, 8, and 3 years old. So he's a busy dad. He's a busy practicing OBGYN, and he is on the social media platforms, which is actually where I found him. So if you aren't familiar with him, I hope you love this conversation. Man, listening to him talk, I just thought you are the type of providers that we need to be sitting in front of when we're having our babies. And I also love the way that he shows up online. So I would encourage you to follow him here after you listen to this. And I hope you guys enjoy it. This conversation is going to be all things induction. It's something he wanted to talk about and lean into. And so that is what we are going to do together. All right. I told Dr. Hunter this before we started, but he is the first man to ever come on the podcast. So we're cheering. I'm really grateful to him for coming on. And we're going to get into that specifically as well as a bunch of other stuff. But Dr. Hunter, thank you so much for coming on here with me.
No problem. Thank you for having me. Also being the first man. This is my first guest podcast appearance. So I'm so excited.
I didn't know that. Okay. Yeah, I'm really excited about that. Well, I'll have Dr. Hunter share later, but he, is on all the social platforms and he can share all that with you guys. But that's where I found him, honestly, was on TikTok. And we were laughing about that too. But he said, I didn't know what I was doing, but I was putting it out there. And here we are. So we're going to talk about induction and some of the big questions that come up kind of over and over and again for all of you about having inductions. Should we, why, when, how? All of that stuff. But I actually first want to talk to Dr. Hunter about being a man in a largely female dominated field. So I think basic softball question there is just why OBGYN? How did you get here? Why does your heart love this?
Right. So it's crazy because when I started, my journey is so interesting to me because when I started, I never even wanted to be a doctor. I was actually trying to copy my sister. And my sister was the first person in my family that I knew of who said she wanted to be a physician. Now, she's not a physician, but she started me thinking about it. So when I went to med school, one of my professors said, my anatomy professor actually said, hey, you should be an OBGYN. You're really good at pelvis anatomy. It comes easy to you. I was like, first of all, that's the last thing I want to do. And I want no parts of any of that. I wanted to be either a pediatrician, a pediatric surgeon, or a pediatric emergency medicine because I love babies. I mean, I love kids and I love the innocence of a child was so beautiful to me. So when I did my rotation, speaking of loving children, I helped deliver my first child. And I remember it was 6 p.m. I know exactly what room I was in. It was the best experience of my entire medical school career. And I always tell people, I chose OB because it was like a lost love. Like I was in this relationship for 6 weeks. We had to end it because the rotation ended. And
so true.
I was like, what is she doing? Like, what are they doing? Like, what's life like? I'm supposed to be over here in pediatrics or surgery and all these, but I just couldn't get enough. So it's just kind of like old love that just bit me, and I just had to keep going.
I love that. It's almost like something, I don't know, it's like the cheesy books that talk about falling in love, this idea that you can't stop it, right? Like once you fall, what are you supposed to do about it?
Right,
and I think again, that cheesy, that idea though, of like the first time I saw birth, I was gone for birth, you know, like that idea of this, and I'm in that camp, like this miracle never gets old. I mean, it really, really doesn't. And I think once it's kind of hooked its claws in you for a lot of people, you just, like you said, you just kind of can't forget about it.
Yeah, at all. It's crazy, actually.
Okay. So being a male in a largely female dominated branch of medicine, though, I'm sure not comes with challenges. I don't want to say it like that. Like you have to fight every day just to be there at your job. But do you ever run into finding, that it can be tough to, I don't say convince a woman to want a male OB, but what are the perspectives you get from people around you? Obviously, patients who end up in front of you probably love you. Like, what does that conversation look like sometimes?
It's funny you said convince, because I feel like on a daily basis, I'm trying to convince somebody that I am the doctor for them. Like that's what I do constantly. And one advice I got a long time ago was don't let people see who you are. Don't try to be someone else, a different physician for them. Let them just choose you instead of you trying to make them choose elsewhere. So for me, I just am constantly just trying to be myself. And my goal with every encounter is to convince somebody to come back and see me again, that they would say, oh, I really like this doctor. He listened to me. He really was trying to hear my concerns, and I want to go back and see him because I feel heard. So that's literally one day that I had that today. Somebody literally was like, oh, I never had a male provider, never had a male doctor before. You're my first one. I'm going to come back and see you. I'm like, yes, win, done it again. That's what like driver, because it's interesting. I thought about this morning. I was like, being a male in an OB dominated field is choosing discrimination constantly. And it's a subtle discrimination where you're like, oh, I didn't really think about it that way. But I mean, it is like I've had people not want to see me because they're like, oh, you're a man. I've never had a male OB. I don't want a man to see anything. Like absolutely not, which I respect, totally fine. But I just constantly have to remind myself that because there are less males in the field, it's more of a unknown. Like, what am I going to get into? And people are fearful of trauma, of bringing up trauma that may or may not have been in their past, or some new trauma they don't want to experience. And I completely understand. You hear these crazy stories, so I completely understand. But for me, my goal is to just try to change the narrative constantly, to just like help people know that I'm not this like weird trying to like sexualize this encounter. Like that is not me at all. I tell people all the time, like, I don't want your problems. I tell their spouses, I'm like, listen, I don't want your boo. I have my own problems in my life. I don't want anybody else's. I didn't do this to add on more problems to me. I don't want your spouse at all. Promise you, at all. I have an amazing wife. I chose one. I don't need multiple. Like, I'm good.
Yeah, no, I mean, it makes sense. And I remember patients, we had at one point, one full-time male L&D. We did LDRP, so all of it, but one LDRP nurse who was a guy. He didn't last very long. He was actually incredible. People loved him. So I don't think he left because he couldn't make it in this on this female floor or whatever. And then we had one male who floated. And so like PRN, he'd show up every once in a while. But there was often that pushback from a patient of like, do I have to have a guy? You know, like a judgment before they've ever been in the room. So how, you kind of talk about this little bit of discrimination. It is true. I'm sure that is in front of you. I loved how you talked about, though, this idea of I'm not trying to be someone for them. Like they have to want me. And I actually think that's such good advice for all of us as we're thinking about, interviewing provider, like male or female. The advice is, find your birth team, find the person who makes sense. And so to be able to walk away from maybe a prenatal or preemptive appointment with the OBGYN or a midwife and say, like, I liked who they were. Like, I didn't feel like they were trying to be what I wanted, but more like, They just are what feels good. Like if we can figure that out, I'm saying we, like all of us trying to figure out how to be our doctor. Like if we can figure that out, I do think that's a huge part of finding right fit, is that you are who you are. And I need that to be what I need, and not you trying to be what I need. So it's so good. Mm-hmm.
Yeah.
I was just with a midwife a while ago who does all home birth midwifery, I think in Virginia, actually, out near where you are. And she was saying that when clients are sitting in front of her, if they ever are asking questions like, tell me like why I should have a home birth, like that type of vibe, she's like, absolutely not. I need you to tell me why you want one. Like you convince me almost that this is what you want. And that's kind of what popped into my head when you brought that up, of almost like, you tell me what you want, and then that I can be able to say, hey, we're a good fit or we're not, and almost like take the onus off of you and put it back on us to figuring that out a little bit. So I love that.
Yeah. Perfect.
I also have to say, one of my favorite OBs that I ever worked with was a man. And I'm like, should I shout him out right now? Maybe not. He'd probably get embarrassed. He doesn't listen to me. What am I saying? But anyways, I remember telling everyone, because we have, I don't know how it is where you work, but like an OB's on call 24/7 for the night shift. And so if you come flying in and you're precipitous or something, like you probably won't get your doctor. It might just be them sleeping in the room. And I always used to say, if I come flying in, he can deliver me. Oh my gosh, I'd be so happy. Like I do not care if it's him. He can deliver my baby. And so that's just, I think, personal experience. I've always felt like often if you are a male in this field, it is because you love it.
Yes.
And so really, like, isn't that to me almost like, let's give you a gold star from the start, because you're here where people are questioning while you're here. And to me, that means, well, it's because you really, really love it and want to be here. So that's kind of the way I look at it when there are men.
When I'm going through med school and meeting all these other people, and we're all trying to discover what we want to do, OBGYN is either a hate it or love it specialty. Like when you're doing this, you either absolutely love it and you want to do this for the rest of your life, or you want to stay far away from it. Which is why when many emergency rooms, when you go to an ER and you're like, man, I don't know if they know that they feel comfortable treating a pregnant woman, it's probably because they don't, because they do not love OB or GYN at all. It's like not their thing. So I know that 100%. From working on the OB floor and the ER calls, and they're like, she's pregnant, get down here.
Right. Nobody wants to touch her.
Nobody, not a soul.
Yeah. Okay. Well, thank you for answering all those questions. I'm sure they're a little bit personal, but I do think it's a question everyone always has for men in the field. And I would say particularly younger providers like yourself, because sometimes we're all like, oh yeah, there's this old OB who's 80 and he's still delivering babies. Like you kind of hear that, but I love hearing from younger men who are deciding to come into the field and why. So I love that.
Perfect.
Okay. So let's get into this induction conversation that we are wanting to have. I think I'm going to say this really broadly first and just say you kind of were like, let's talk about induction, and seemed like you had a heart for it. So my first question would actually be why? Like, why do you want to talk about induction a little bit more?
It's funny because I think not only OBs, but just providers as a whole take care of all pregnant women. There's this negative stigma about inductions from all parties. And I think inductions can be a very powerful thing. And I think what I try to do is take some of that negative stigma away. Yes. Does natural labor, meaning you show up and you're in rip roaring labor, does it have better outcomes, better as far as like safety for mom and baby? Yeah, of course. But induction does have its place too. And I think we have to take away this evil induction idea that's there, because to me, I feel like it's definitely warranted. And over the years, taking care of so many pregnant women, I realized that some people have reasons for it, but they feel guilty. And I feel like that's wrong, that you shouldn't feel guilty for wanting that. Sometimes it's social, right? You have a spouse or a family member that's either military or needs to go overseas or something. And you're like, man, I really want this person here for my delivery. Like, to me, that's a viable, normal reason to request it. Or you have a medical problem and people are so torn about induction, not induction, and they sometimes make decisions that can hurt themselves or their child without even knowing it. So that, to me, that's why I feel like we have to take away that negative stigma that comes from inductions. Yes, does an induction versus regular labor, do inductions cause more C-sections? Of course, yes. But it doesn't mean it has to be that way. The data tells us it's not normally. So as long as we take into account different ways to start said induction, I think you can have fantastic outcomes regardless of how you want to deliver.
Yeah. I talk about this a lot, or it's definitely, I feel like the base or the foundation behind so much of teaching and what I love doing online as well is this idea of, I feel like there's been this pendulum swing and we have this, everything was like too clinical. We were being told what to do, exactly how to deliver, how to breathe. Like everything was being very prescriptive for us. And so there's this pendulum swing now that's happened as a pushback against that. And I think this is good because that type of birth, that type of experience wasn't serving a lot of us well, if any. But now we have this swing of like, don't say yes to anything. All interventions are bad. And we have what you just said, which is someone wanting an induction because I don't know, their mom's in town. It's the only week and she's their favorite person. I don't know, whatever reason it is, you know, and now they're validating a choice that they've made and they've been thoughtful. And so they're almost nervous or embarrassed to tell people. And so we have this swing now where it feels like if you want a cervical exam, everyone's like, why are you doing a cervical exam? If you want to be induced, why are you being induced? If you want whatever, fill in the blank, it's like, why would you do that? And so I think we just need this pendulum to just sit in the middle and stop being on either side and say, hey, this is the goal. You have information to make a decision. You are respected for your decision, whether or not it lines up, you know, with evidence or what I think, I being you, the provider, whoever, and like, just let it sit there and let people say, cool, thank you. Here's my choice. And then we carry on. And I really think induction falls into that pendulum swing of like, you've got these really aggressive opinions against it without that kind of good recognition of there are times it's really necessary, it's helpful, it's needed, it's wanted, and all of that can be really valid. So let's put the pendulum, back where it goes.
And I agree. You know, I was thinking, same way you were saying how the field had been so, I think, paternalistic for such a long time. You have to do this. You have to do it this way. That you must show up. You got to do this. And so I agree 100%. And I think that we as providers, no matter who's taking care of pregnant women, have to do a better job at not only presenting information and presenting options, but being okay with choice and whatever choice people take. And sometimes I think we have to get out of our own, provider-wise, have to get out of our own way because we feel like someone should choose X. And I'm like, well, why would you give them these options if you are saying they need to do this thing? Well, we have to do a better job of counseling now because I shouldn't tell you a thing that's going to be dangerous for you if I know it's going to be dangerous for you, right? So some of this we have to take ownership too, and how we counsel and talk to everybody, because we do many people a disservice because sometimes our own personal bias comes out. You shouldn't be. I don't even know why you would even think about induction is what some people will say. Like, and so now you feel dismissed, and I think that's a big issue too.
Yeah, absolutely. Will you talk about really quickly, just vocabulary, almost the difference between induction and augmentation so people kind of understand what that might mean for them? Yeah.
So the way I usually explain is an induction is going from 0 to 60, right? You are doing nothing. Your body is not in labor. You are not even contracting. You may have 1 or 2 here and there, but nothing is regularly happening. And we have to give you medication to basically start labor, jumpstart your labor. And augmentation is you're starting to do a little something, right? Your cervix may be slightly dilated, 2 or 3 centimeters. You may be in this early latent labor, as we call it. So from cervix is either 1 to 5 generally, and your labor may stall out. So for instance, some people will show up to labor and delivery. Their cervix will change from 2 to 4 centimeters. And then as time takes on, the contractions start to go away and they feel like the contraction is not as strong as what it was when they first got there. So an augmentation is like, okay, we're going to add Pitocin to help you have more regular contractions. Outcomes for augmentations are much better than, again, induction as far as if vaginal delivery is the endpoint, but still it's not the same. And I think some people do put the two together in the same boat. Every person that gets Pitocin is not being induced. And so that's the big key difference. But an induction is just literally 0 to 60.
Hey friend, quick pause for just a second. If you are listening to this podcast because you want to feel more prepared, more confident, and less freaked out about birth, that is exactly why I created the Your Body, Your Birth course. This birth course will not tell you what kind of birth you should want, and nobody has the right to do that. It is about helping you understand what's happening in your body, what your options actually are, and how to walk into your birth feeling grounded, excited, ready, instead of overwhelmed and scared. When you have education like this, everything changes. Your mindset, your conversations with your care team, and the birth experience itself. No more relying on random opinions, okay? Stop scrolling. Take intentional action with me and start trusting your body, your voice, and your decisions today. Head over to www.thelabormama.com/birth, also linked in your show notes. And be sure to use the code podcast at checkout to save 20% and start working towards this better birth for you right now. Okay, let's get you back to the episode.
Yeah, that's perfect. I think that's important because you'll hear things like, like 50% of labors in the US utilize Pitocin, and you go, whoa, that many, you can think that many are being induced, or what does that look like? And so it's still valuable, I would say, for everyone to understand what's Pitocin do, what's it for, how's it support, how's it help, how can it hurt, all of that. But just understanding there's like different ways it can be utilized, understanding the or any of the other induction and augmentation tools as well, but just understanding that it's not all this one basket, like you said. Like if you have Pitocin, that means you're being induced. That's not necessarily true. And so I think that patients can come in and be thoughtful about how things are used and how that applies to what's going on with them. So it feels like part of this induction conversation for sure. So you have mentioned a little bit when you were just talking about induction versus augmentation, you mentioned the phrase like reasons for induction. So let's talk about some of those. So again, we're talking about nothing's going on and we're going to put you into labor. What are some reasons for that? How should we be thinking through some of that?
The most common is elective, what we call like, I just want to be induced for a number of different reasons. And again, I support, you can just want to be induced for just being tired of being pregnant. TOBP, as some have termed. I'm just tired and I just want to have this child. And I respect that wholeheartedly. I've never carried a child myself, but I have seen my wife be pregnant and it was not beautiful for her. And so I understand, like firsthand, I understand. I help roll her out of the bed every day.
I want to interrupt you for a second because the TOBP diagnosis, that's air quotes, people. It's not a real diagnosis, but would have to be after 39 weeks, right? So talk to us about that too, because I know that plays into elective inductions and that desire.
There was this, years ago, there was this definition of like term, not term coined. So after 37 weeks, we coined your full term, even though most people think it's 40, but after 37 is full term. There's early term and then what we call just regular term. So you used to be able to induce anyone after 37 weeks. If you were tired of being pregnant, 38 weeks, you could just have a baby, show up, have a baby. And then we learned that more of those babies were admitted to the NICU and had worse outcomes. But if you induce after 39, that's sort of a magical sweet spot as far as lowering the risk of issues for both mom and baby. So now the recommendation is not to electively induce anybody before 39 weeks, unless you have a medical reason to do it.
Right. That's perfect. Okay. Carry on with the other reasons besides TOPB.
Another big one is high blood pressure. So any kind of what we call hypertension, any kind of high blood pressure disease in pregnancy, whether you had high blood pressure before you got pregnant, you had high blood pressure when you got pregnant, gestational hypertension, whether you have some sort of preeclampsia, either the what we call mild form or severe form, or if you have any other version of like high blood pressure disease, like HELP syndrome, for instance, even though you don't have to have high blood pressure would help. But regardless, any kind of blood pressure spectrum, that is one big one. Diabetes, and they've just changed the guidelines for diabetes where if it's uncontrolled, then yes, before 39 works beautifully. If it's controlled, even on medications, 39 weeks is actually a good sweet spot to shoot for, as long as baby's not too big per ultrasound guidelines and there's no other complications going on. And then there's a bunch of others, like if you have some sort of history of lupus, for instance. Some of my ladies with lupus have a higher risk of high blood pressure. If your lupus is becoming more out of control, then yes, you need an earlier delivery. There's others like you have placental issues, so placenta previa. So if your placenta is over the cervix and basically blocking the way for the baby, the closer you get to term, the more likely you are to go into labor, and contractions with the baby pushing on that exposed placenta over the cervix can lead to bleeding, which problem for baby. So another big one. So there's this whole long list, and I didn't even get into multiples like twins and triplets and all that, but it's a long list per ACOG, the American College of obstetricians and gynecologists that they put out for all OBGYNs in the country. And then there is this caveat that's there too. So if someone has a history of traumatic birth, and traumatic birth is not, you are traumatized from your birth, but more traumatic, meaning from a medical standpoint, near-death experience, something happened in a prior birth and you're pregnant again, then you can consider early delivery before 39.
All right. I want you to speak a little bit more about inducing for baby size, because you mentioned it when you talked about gestational diabetes. It comes up a ton. And I feel like that is one of the induction conversations that is the most confusing for people when they hear, they told me my baby's big, they want to do another ultrasound, I'm 38 weeks, or 37, they probably aren't. Yeah, maybe a little bit earlier, but a later term ultrasound, induction for size, and really nothing else. And that of like, do I have to do this? So give me some thoughts on that one.
So I'm gonna give you what the data says and what the guidelines say, and then my personal opinion, because I got opinions. But the easiest to understand is smaller babies, we have way more data on, and we're better at accurately predicting smaller baby sizes. So if you get an ultrasound and it says your baby's 4 pounds, 1 ounce, we're really good at when that baby comes out, it's within a few ounces of being pretty correct, generally. Depends on where you get your ultrasound, who did it, etc. But for the most part, someone experienced, and folks who do this all the time, that's generally what happens. And there's recommendation based on how small. And we think about size of a baby, like when you take a child to the pediatrician and they say, oh, my baby's the 90th percentile. They're like, oh, you got a big kid. So my child's bigger than 90% of other kids at that same age. We do the same thing for pregnancy. So someone has already figured out what the average size is of a child at each week of gestational age of pregnancy. So 36 versus 39 and 40, etc. So if your child is less than the 10th percentile, that means your baby is at a higher risk of needing help after delivery, whether feeding issues, breathing issues, etc. So we usually will say you have a small baby, meaning less than the 10th percentile, we recommend an earlier induction. Early meaning before your due date. And generally it's somewhere between 37 to 39, depending on how small the baby is. And we say early induction, but early delivery. And one caveat I do want to put out there is that when someone recommends an early delivery does not equal C-section. So it just means we need to find ways to get the baby out, and that's usually an induction more commonly. On the flip side, there are guidelines for babies that we deem too big, right? There's some data to show that when a child is more than a certain amount of grams, so 4,500 if you have diabetes, or 5,000 if you're don't have diabetes, and that's not pre-diabetes, that's just like overt diabetes or not, that shows that there's a higher likelihood of your baby getting stuck coming out, or issues with breathing, and issues with blood sugar control, etc. after delivery. Now, that's what the data says. My opinion. I think we as providers induce way too many women for what we deem as big babies, and don't focus more on telling people that, hey, we're not very accurate at predicting very big babies. We're really good at small ones, but not as good at bigger babies. Ultrasound, they quote, is good plus or minus 20%, which is a big deal. So when you get to full term, 20% is a difference of like 1.5 pounds, which is huge, going from 7 pounds to 9.5 or 7 to 5. But generally, it falls under from what I've experienced. The other thing I tell people too, especially if it's your first time, if you get an ultrasound, and let's say that baby is measuring 9 pounds and you are 39 weeks and 2 days, some people would say, hey, I would recommend an induction. I would say, I would tell you that that's part of the recommendation, but I would give you the option. No one knows if your child is going to fit until it does or does not, right? So for instance, I have a lady that I took care of. I took care of her in her fourth pregnancy. Her prior 3 babies were all 10 pounds, 10.5, 10 and some change. And that fourth child was 12 pounds, still fit vaginally. Who was I to tell her that it wasn't going to work? If your pelvis is what we call tested to a certain size, meaning you have proven that you can deliver a baby X amount of size, that's a way better predictor of success than me just guessing. And I feel like that's part of that paternalistic view again, as many providers will say, I don't think the baby's going to fit, but I don't think the baby's going to fit is not a clinical diagnosis, nor is it a strong suggestion. And I'm not saying go against your provider's suggestions, but I am saying you have the right to say no. You have the right to say, I'm not comfortable with induction, especially if someone just says, I don't think it's going to work, because I don't think it's going to work means nothing. At least to me, it means nothing.
Yeah. I mean, I feel the same. And I forget what the statistics are about, like true cephalopelvic disproportion, like the head actually not fitting through the pelvis. And the actual number is so incredibly small, right? Of a baby truly that the head like can't fit, right? And that doesn't mean that doesn't happen. It doesn't mean babies aren't in funky positions. And then we run into that because of other reasons as well. But like, I just think that idea of someone without ever giving you a chance to quote unquote, prove your pelvis, to just say like your body has made a baby that won't fit. I personally really struggle with that one too, because typically that's not true at all. Now, are there other things that can impact labor that can cause fit issues? Yes. And sometimes induction can be part of that. So like, then that the waters get like a little murky with that too. But I think that conversation of inducing purely for size, especially talking big babies, like you said, and when they're not over those boundaries that you mentioned of like the 4,500 and the 5,000 and a first timer, I just feel like that's so complicated because they hear, oh no, I'm going to have an issue. But really none of that, like evidence doesn't really say you should be induced. If we're talking about under those numbers that you mentioned, like it doesn't say, it's an offer, it's a suggestion, it's a possibility. So I just think that's such a hard choice for those, again, especially that first timer to make who's like, can a baby fit? I've never done this before. Oh shoot. And just that feels like a tough one for me. So thank you for clarifying it. I think maybe takeaway of that is knowing that alone, I feel like a lot of people come to me and say, hey, this is the reason, but there's nothing else going on. What do you think? And it's like, well, one, I can't tell you what to do. But second of all, like, go ask more questions, right? Or ask about follow-up or ask about delaying a week and having the conversation again, like just pushing back a little bit with, you don't even have to say I'm absolutely going to induce or not in that scenario, but even just saying like, can we address this in a few more days? Maybe I'll kick into spontaneous labor, like being comfortable having conversations like that too.
And I had someone else too, who she was moving from a different state and came to where I was. And so when I saw her, some other providers had already told her, hey, your baby's measuring ahead, I think 3 weeks ahead. And they had put in her head, in her mind that, hey, I just need to let you know, you might have to have a C-section. So now she comes to see me. One of her first things she wanted to ask me is, are you going to make me have a C-section? And I was like, well, first of all, how are you doing? How is life? And where is this coming from? So you have to like break down some of those barriers and then say, okay, let me tell you where they're coming from. And then let me tell you what the data shows, and then I'll give you my opinion. And that's usually how I like to take it. I don't like to usually when I talk to people, I tell them this is either opinion or this is data. And I will delineate the two, because I think the data is more helpful at helping you make really, really good decisions as far as like, what are my outcome likelihood? And then my personal experience just kind of gives that personal touch to say, oh, okay, if I was his sister, this is what he would tell me. So for her, luckily, I got to her earlier, so we didn't just have one meeting and then she had to deliver. And she ended up delivering. Baby was fine. She delivered vaginally. Her baby was almost 10 pounds, but she pushed it out and it worked out beautifully. So, fantastic. I'll take that any day. It doesn't always go that way, but I think being comfortable in your choice is helpful when the outcome doesn't always go the way we think it may go or expect it to go.
Yeah. But that really starts with, like you said, when we started, of providers being willing to recognize that it is your choice. And this isn't like a pride hit against me if you go against what maybe my recommendation would be, like that it's just your choice and giving them that choice. I want to mention, because we've talked about, or I want you to talk about, what about inducing for dates? Because that's the other one that I think comes up a lot as well. And it's again, like, do I really need to induce because I'm 40 and 4 or whatever? So what about that one?
So again, I get my personal and also the data.
Course.
So from a suggestion standpoint, data wise, there was this huge big push back when, I was a resident. So this was 2019 is when this came out, 2019, 2020, when the ARRIVE trial came out. And so at the time, that was like a big, huge, the ARRIVE trial is this trial where they looked at women who first pregnancy, they had never gotten pregnant before, never delivered anything. They looked at women who were induced at 39 weeks and those who were induced at 41. Because prior to that date, Inductions at 39 weeks were sort of faux pas. Like, we didn't really want to do that. We just generally let people get to 41 and say, all right, it's time to have a baby. And for the most part, and that was sort of the cutoff. And so some people are like, why can't I do a little bit earlier? And so that's why they did this. And they found that the outcomes were similar. There was no increased risk of NICU stay, no increased risk of C-section, et cetera, et cetera. So from a suggestion standpoint, the reason why we generally recommend not going past a certain time frame past your due date is there's risk of stuff. One of that stuff is stillbirth, which is the one that scares everybody. Right. I always tell people my goal when I take care of pregnant women is to make sure that you get to the end, you take that baby home in your arms and you get to raise that little one. And my goal is to help you make decisions to make that happen. So from a stay pregnant longer standpoint, I will tell people that risk goes up of stillbirth. And I've seen it where you show up and the baby just doesn't have a heartbeat. So that's a very scary thing. So I'm scarred by that. So that's why I make recommendations I do because of that from a personal standpoint. But the data just says 41 weeks to 43, the further along you go, the higher risk of stillbirth. From 41 to 43, the further on you go, the higher risk that your baby gets stuck is from a size standpoint. And so this thing called shoulder dystocia where a baby gets stuck and then we have to do all these maneuvers to help get the baby out. From 41 to 43, the risk of the baby having this thing called lanugo and not being able to keep regulate its own temperature goes up. So the risk of NICU stay goes up. And then the risk of something called transient tachypnea of the newborn, meaning the baby's born and just for some reason cannot keep its oxygen levels high enough and breathe well, which is an oversimplification of TTN, but roughly that.
It works. It's great.
Yeah. So, that those risks go up. So that's where this suggestion of 41 weeks, hey, have a baby. And then that's where the 39 elective induction comes from. What has not been done is this whole, what about I just induce at 40 weeks and 2 days, 40 weeks and 4, etc. From my personal experience, I tell people all the time, I love a good 40 and 2, 40 and 3 induction. Because it's not quite 41 with the drama, and it's not quite so early with 39. It still gives you a little chance. So that's my personal feeling. I love a good 40 plus week induction because from what I've seen, the outcomes tend to work pretty well. There is, I think, a follow-up study that should happen is what's the difference between 39, 40, and 41 starting from scratch? And then what does that look like? Because I bet there will be more women there'll be a lower risk of C-section and better outcomes with 40-week inductions than 39 and 41. So a little controversial. That's my personal beliefs. There's no data behind that. It's my personal beliefs. But that's just where I fall.
Yeah. I mean, the ARRIVE trial, anyone who starts digging, I think about induction, that trial comes up, right?
Every time.
And I do think that 39-week idea can feel a little bit shocking for some people. Like, why would we ever induce a perfectly healthy pregnancy at 39 weeks? Mm-hmm. Alternatively, there's people who are so tired of being pregnant that they're like, this is out there. I believe it. Let's do it, and like sign me up. And so I do think it's just important to recognize that data is out there. I mean, there's a lot of people who have complained about some of its limitations, like you talked about as well, this idea of, well, also what about at 40 weeks or 41, the gap between like a 39-week induction or a 41-week induction, like there's a lot of data and a lot of bursts in between there. And what would those tell us as well? You mentioned the idea of like unplanned C-section, because I think with induction, that a huge part of that conversation too is if I am induced, does that increase my chance of C-section? The ARRIVE trial addressed some of that as some of their outcomes. So what do you talk to your patients about when that is part of this induction decision conversation and them saying, I don't want a C-section. So how does that play into this induction choice?
So some of this is, have you had a baby before and have you not? So when you look at induction success, meaning have a vaginal delivery, from a never had a baby before instance, there's been a lot of studies done that kind of tell us, hey, if you show up in labor, meaning cervical change or in having regular contractions, your chance of a C-section is much lower than if you showed up doing nothing, cervix is closed, and needing an induction. It is sometimes very, very difficult, can take days to go from closed cervix to 4 centimeters. Like
to 4, just 4.
Just 4, like
I know.
A long time. Right. So you're just like praying like, Lord, it's 4, please. So it's just like, it can take a while. And some of the data does not talk about this, is what I've seen is some people are just over it. Like they just, from a mental standpoint, feel like they just cannot handle more, right? 2 days of going from 0 to 4 makes it seem like going from 4 to 10 is unattainable. So there's some of that in there too. There's a fatigue factor. Some hospitals don't let people eat, some do. So there's an energy, a fatigue, I can't really, this is just too much for me that's built into that. And I think that's where some of the numbers come from. But if you've had a child before and you either need to be induced or you want to be, then the success rate is higher because your body has proven that it can do it.
When you say success rate, you're talking about a vaginal delivery,
correct,
right?
Yes, vaginal delivery. Okay. Yes, thank you. Because I also do hate the term success rate because it is quoted out there. But I'm like, it's successful just having a child. Like just getting pregnant, delivering a baby is successful. But yes, vaginal delivery. So it's different, and it's different for each person. So the more vaginal deliveries you've had, the higher rate of vaginal delivery in the future, even with an induction. And the time from start of induction to delivery also can become much shorter too. So I've had some people who've had 3 kids before, all induced, 4th induction. I give them this pill called misoprostol, and they deliver like 6 hours later. And they go from 1 to 10 and boom, have a baby. And like that's also reality too. So the history is super important, especially with prior births. And I think that's an important part of the conversation that sometimes goes missing.
Okay, that's great. I mean, I think I would say like the majority, if not everyone, that is the primary outcome. Not everyone. I mean, obviously, if we're talking about later term or stillbirth, like that being a fear as well, but it just feels like that cesarean conversation is just hand in hand, like tied right next to the induction conversation, no matter like who you're talking to. So ultimately, I feel like what I'm hearing is the gift of having a provider who will walk through these things with you and let you decide. I mean, again and again, we keep reiterating that that's the gift, right? Of saying, here's the data, here's some anecdotal stuff. So this isn't data. Here's personal feeling. How are you feeling? Like putting all 4 of those things together is just it's such a gift when you're making a choice like this. The last thing I wanted to ask you about related to induction, and maybe those who are saying, hey, can we delay right now? Or I just don't think I'm quite there yet. And I realize this might depend on the reason for a recommended induction or whatever, but what are some other options for them in the interim? This idea of maybe NSTs or screenings or BPP. You don't have to get really technical about all of them, but what are some things maybe that are good knowledge for them to have if they're thinking, I want to pay attention to what's going on, but I also don't want to induce yet today? What are some of those?
So just like you said, fetal monitoring is huge, and we have good data about if the monitoring is reassuring, meaning everything looks beautiful, then the likelihood of your baby looking good over the next week is high. It's not perfect, but it's what we have. So you can always, to me, I think if you make the decision to say, hey, I don't want to be induced right now, but someone is strongly suggesting it and you want to put it off a week, a good middle ground is, hey, can I get monitoring on my baby? And the monitoring is basically just putting your baby on the monitor, looking at what the baby, seeing what the baby looks like on the monitor, and then ultrasound, looking at different factors on the ultrasound to tell us how well baby's doing. Because sometimes when you do that, you'll catch things, right? Baby can have low fluid, the heart rate is not really looking too hot. And then now we're having a different conversation. And I think monitoring in between is beautiful. And you can do monitoring 2 times a week if it's more high risk setting, or once weekly. And you can do it every single week until you show up for delivery. And I think that's totally fine. Now, every facility, the way they do it is different. I used to work at a place where many people would go to the hospital to do their monitoring, and then after they would come up to the office and you would talk about the results of everything. So, everyone does it a little different, but that is a big option. The one thing I would tell everyone not to do is don't get mad at the suggestion of an induction and just disappear and then decide to show up to labor and delivery a month later, because that is asking for drama around a delivery that you don't want at all. Yeah. So I would say,
No, that's perfect. Because I think that's what I want people to hear. And this is, if you're someone saying like, I respect all these reasons they've talked about, but if it were me, I think I'd still, want to delay. Well, there's options to continue to pay attention to things, but still, try to get things going at home. Like that you don't have to just disappear. I think sometimes I hear the statement float around of this idea of, if they're scheduling your induction, that means you don't need one, right? And so there's a lot to unpack there, I think, but that idea of like, oh, well, if they're doing it in 3 days, then that means I don't need it at all. And just saying, hey, if they think you need it in 3 days, maybe talk to them. If you don't want it in 3 days, talk to them about what to do over the next 7 days after that or something, and not just have it be such a thing, like a black and white thing where it's like, well, nah, just 0. Let's just do 0. And again, it depends on why and what the reasonings are for it, but that there's often some options in the in-between if your choice is no, not right now, or not in 2 days or whatever. So.
And sometimes the days they suggest is just a scheduling thing, right? They know they're looking at the schedule like, ooh, we can't do it on the weekend. I know there's something going on this day, yada, yada. So if it's a scheduling thing, like you can get around that. Like that is a different conversation, but you don't know until you ask too. So that's why I usually would tell people like, you know, if you have a date in mind, tell them. If you're like, I want to get to this point in my pregnancy, let them know. Because then you can have a realistic conversation. Well, I don't think you're going to be able to get there because of blah, 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 blah. Or, oh yeah, we could change it to this day. Let me ask, you know, so it's just, you just have to be open and just don't disappear off the face of the earth. Like show up and go back, maybe find a different person to talk to if you're angry, just so that we can still take care of both you and baby and make sure everything's going well.
Yeah. Here's my reminder too, that if you pick a date for an induction, it doesn't also mean the baby will be born that day. So just remember that. Maybe. I hope so.
Yes.
But maybe not if you're picking the perfect birthday.
I know. I had somebody who was trying to pick like based on the calendar and astrology.
Yeah.
And I was like, let me tell you something. Your baby cares this much about any of that. This much.
My kids love the stories of babies born on, I mean, this happened like twice, but like twins born on different days or whatever. But I'm like, you guys, you can't control it. Like one time, you know, sometimes they pop out and then the other one comes, like you can't really control what's going to happen with that timing, or that idea of pushing at 11:59 p.m. And it's like, sorry you wanted today. It's not happening or whatever. So just a little reminder of how it might go.
And I've delivered babies on 2 different days. So I myself have done that.
It's wild.
So, yeah, it's crazy.
One time I was the nurse for twins, and we ended up having to do Pitocin to get the second one to come down and deliver. Like the first one we delivered in the OR because that's often how you do it. Yeah. And then put her back in the room and did Pitocin, and the other baby came later. It was the craziest thing. So
I love that.
as one time, but you know, it could happen. Yeah. Okay. Do you have like anything else that you're like, ooh, I want this plugged into this conversation that we just had that we didn't cover?
The only extra thing I would say is I think the nice thing about pregnancy and the beautiful part about it is that you have options. You have lots of them, and you have the ability to find people that make you comfortable and that you feel comfortable with. And my other big plug is the way pregnancy is seen and the way women are seen, the way we take care of is changing. The way reimbursement is happening is changing, and that's going to change the way we have conversation around prenatal care and how we now have been pushing people to deliver. Like if you're seeing me, I would want you to deliver where I deliver, but some people will see me and say, I'm planning to deliver at this other hospital. And from a provider standpoint, from a billing standpoint, most companies, practices don't like that because of billing, but that's going to change soon, hopefully. They finish doing what they're doing. So the ability to choose more providers is going to open up, and to see someone during a pregnancy and to deliver at the place you feel comfortable with will go hand in hand, I think, a little bit more. And I'm just excited about what's coming. But I also want people to know, like, you do not have to be married to one person that you're seeing. Like, you're allowed to shop around like we actually expect it. And that's okay. And that's totally fine to find someone you are very comfortable with. Now, they may be out of network, but if you're comfortable, great.
Well, Dr. Hunter, we cannot have the insurance conversation right now because that would take far too long. But, you know, guys, shop for a provider. That's okay. That's what he's saying. Hopefully they deliver where you want to deliver. Look into that because it doesn't always line up. Hopefully it will.
Yes.
Insurance is another podcast. Not by me. Not by me.
Yes, Lord.
Okay. Will you tell everyone where they can find you on social media like I did?
Oh, sure. Yeah. So I'm on TikTok, Instagram, Facebook, and YouTube. You can just look up literally Dr. Dr. Ahan, Ahan Hunter, and you'll find me all platforms.
Okay. Do you have a website? Are you doing other things? Obviously, you're practicing and seeing patients and delivering babies, but that
the
need
website
to be out there
is in the works. I haven't done it yet. I'm partnering with my wife to do some stuff. So she's a nurse herself. So we're trying to do some things. So that's to come.
Okay, sounds good. We'll put a pin in that one. Last question I love asking. What's something in your life right now? It can be big, small, anything that's just bringing you a lot of joy.
I, for the first time, have signed up to be a soccer coach for my son's soccer team. And I have never done this before. Do I know a lot about soccer? I know enough. But I'm just so excited because I know how much my son enjoys like being outside, soccer, all the thing. He's 9 years old, and my baby, the 3-year-old, is also going to play too, but I'm not doing his team because I can't. Mental patients don't have it. But 9-year-olds I can do. So I'm so excited, actually.
I'm excited for you. My husband just started doing that with our kids a couple years ago. I'd say like 2 years ago. And he loves coaching those kids so much. Our oldest is 9, and then we have 3 more underneath that. So we have some younger ages he's done, but he loves it. I mean, the way your face just lit up, I'm like, that's how his face looks. So I hope you love it because it seems like the sweetest thing, really, for both of you.
Yeah.
So.
And it's crazy. Like, I'm an OBGYN that does do 24-hour call, but somehow I have time to go coach soccer during the week and on the weekend. So I'm like geared up. I'm so excited.
My brain was wondering how you're going to make that work with your schedule, but you'll figure it out. It's going to be great. Thank you for giving me an hour of your time. I know you are busy and a dad and all the things, so I really do appreciate it.
No problem. Thank you for having me. I truly appreciate it. I'm glad to be the first guy. Hopefully more to come.
Yeah, that's the plan. Thanks, Dr. Hunter.
Perfect.
Thank you so much for listening to the Lo and Behold podcast. I hope there was something for you in today's episode that made you think, made you laugh, or made you feel seen. For show notes and links to the resources, freebies, or discount codes mentioned in this episode, please head over to loandbeholdpodcast.com. If you aren't following along yet, make sure to tap subscribe or follow in your podcast app so we can keep hanging out together. And if you haven't heard it yet today, you're doing a really good job. A little reminder for you before you go. Opinions shared by guests of this show are their own and do not always reflect those of myself and the Labor Mama platform. Additionally, the information you hear on this podcast or that you receive via any linked resources should not be considered medical advice. Please see our full disclaimer at the link in your show notes.